Here is Dr. Corinne McIsaac, and I've got just a brief bio here for her, but I think you need to know who she is, some of the work she's done, and what she'll be presenting on for us. So she's a successful health educator, researcher, and entrepreneur. Her passion for improving the Canadian health system through outcome measurement is both inspired and informed by 25 years of experience as a nursing clinician, manager, consultant, and educator. Corine's rapidly growing company, Health Outcomes Worldwide, develops and delivers innovative outcome measurement tools, relevant data, and strategic direction to health organizations in all sectors of care to help organizations facilitate improvement in patient care while building greater fiscal and human resource capacity from within. Dr. McIsaac is also an accomplished author, researcher, and speaker. And today she's going to be talking to us about, among other things, OLTCA's wound care research project findings, including such things as staffing, supply cost, and best practices. Thank you.
Well, thank you, John, for the doctor title. Not quite there yet, just a little titch to go, but thank you. My perspective is a little bit different, and I might plead a little bit ignorance in the beginning here. It's really, we've been collecting data in long-term care for about 10 years. So what I did is I was part of the group that Kevin and Tony presented with yesterday. Unfortunately, I was at another conference, and I'm trying to do a little bit different in this one. To really, I think the title I came up with after all the things that I looked at, are we using the right information and the right data to really drive your high-intensity needs, the funding? When Elaine was going over her presentation, and I didn't know that back therapy, and I have no relationship to KCI or any of the vendors, was not covered. It was a little bit of a shock, because I think if we collect the right data, you guys can actually measure whether or not back therapy is effective, if we do it right. It's not just about going around counting pressure ulcers, right? There's so many more data points. So hopefully I'll be able to provide a little bit of insight. So the wound care problem, you guys are speaking to the converted here, costs a lot of money. We spend a lot of money both in Canada and the US. Lots of pain and suffering, lots of people with non-healing wounds. And best practice is only implemented about 10% of the time. I have two different numbers. That came from a physician in Calgary who's done some work on best practice, which is a little bit, I don't know if you guys would agree with that. So from that, we have really poor healing, and we waste a lot of resources. Like, we spend a lot of energy doing things, I think, that are not really effective. So it's a really big problem, and you guys know that. The other thing is, residents have a lot of wounds. And I think as I go through this presentation, you might think should be knocking my head against the wall here, but, typically, and this is data from our data set, this is we looked at about 20,000 patients, many from Ontario, and pressure ulcers, skin tears, and trauma, we have lots of wounds. So we know that. The other thing is, we have all these best practices, but we don't use them all the time. What's up with that? Sometimes it's boggling for me. And here in your province, you guys are world-renowned with RNAO best practice guidelines. God, the new title now for their best practice guidelines are International Affairs and Best Practice. So we have the evidence, but we're only using it a little bit of the time. And the other really big thing I think we have to think about is this transfer from knowledge to practice is really complicated and requires a lot of strategies. The other thing we have is those baby boomers that are going into your nursing homes pretty soon. And boy, are they going to be expecting something different, right? Consumers expect that evidence that the healthcare system is both efficient and effective. And I would argue that we're very inefficient in healthcare, and it's very sad. And I'm going to show you the data. I'm not just, saying this out of the blue. We're not consistently, I think that's the word that needs to be in there, effective or efficient. And it's very sad. So, we have a little bit of an inconvenient truth here, whether we like to believe it or not, the poor polar bears and global warming. But one reference says that about 30 to 40% of our patients are not receiving best practice. Would you guys agree with that? Because we're all people, right? So we try to do the best we can, but sometimes we use our experience. And sometimes we go by what the doctor orders or what somebody else said was the right thing to do. But what this group is saying, this reference is saying, we don't always go to the evidence. Like if we looked at negative pressure therapy, my goodness gracious, there are randomized clinical control trials up to here that support it if it's used properly. But what happens is, unfortunately, people put negative pressure on. In their own insert, it says, if there isn't 30% closure on week 2, get rid of it. So if we were using those measurements and those tools from randomized clinical control trials, I think we'd have a better shot here. So we have lots of problems. We have evidence. We're not using it. And then there's all this research. I mean, I've done a lot of education in my career, and about 10 years ago, I could go into a lecture and probably just updated a titch, like 1 or 2 references. Now you have to spend about 30 hours looking at the new evidence. So this is a turn study that was done on turning patients in long-term care, and Ontario Homes were involved in it, and it was really quite exciting. But it's basically talking about we shouldn't be turning patients or residents every 2 hours. We should probably be doing it every 4 hours. So there's all this evidence that we have to keep up on. So you can see how it's a mounting problem. The other thing, and Dr. Bolton has done a lot of work in wound care decisions are often based on clinicians' opinions, varying from one practitioner to another, which results in inconsistent assessment, care, and wound or patient-oriented outcomes. So back to we're not always okay. I better put that down. Who in 2013 put out, a white paper on wound care. And, some of the points were really well taken, but the third one, the burden of wounds is relatively unknown in Canada. We know a lot about wounds, but the problem is a lot of the data that we have sometimes doesn't get published. So we can't say, oh my God, they didn't know. If you're not out there publishing it, you got to do it. I'm going to spend a little bit of time on the Kai because I'm really, for you guys, and I can be sort of, play a little bit dumb here. I'm really worried for you guys. If you guys are using that data for wound care, oh my God, we're in big trouble because it underestimates, and I'll show you, it underestimates the prevalence and the cost. So it's scary. It's a bit scary. The other thing that we know about wound care, which this is where I do bang my head against the wall, is that poor care, so this is somebody with a venous leg ulcer, costs about $104,000, and good care costs about $1,100. So that's another thing we know. You can see how this story is building, right? We need to do some things together. Just another example to show you, we've done a lot of looking at the data now, and best practice not only costs less, people get better quicker, sometimes 70% of the time. And this is the data, this is just one example to show you. This is looking at a venous leg ulcer with best practice closed in 4 weeks and with not so great care in a little bit more than 7 weeks. If I looked at some of the data in long-term care and looked at pressure ulcers in particular, best practice care is about $2,400. When we're not doing good care, it costs us $4,000. So, what are we doing? I'm struggling, as you can see, with trying to figure this out, and maybe you guys will help me figure it out. The other thing is, if people track care, wow, what a difference. And I mean track by using some sort of an electronic, system. The one that we use is called, it's an application called How to Track, but there's lots of them out there. So this is an example of a home in Nova Scotia that implemented a best practice approach with very specific tracking. And their outcomes were amazing. They decreased their prevalence rate from 12 to 7% in 10 months. It's one of the first thing they did. They decreased their pressure ulcer prevalence rate by 25%, down to 3%. So one of the lowest, in our database, we have about, I'd say we have probably, I better not quote the number on long-term care, but we have thousands and thousands of patients in our database from long-term care. So when we can compare you to our database. So they are one of the lowest in the country. They run around about around 3%. They also decreased their skin tears by 50%. Okay? So unbelievable stuff that they've done. And also increased pressure offloading. So all those best practice things. Another group in North Simcoe. What they did, best practice approach, decreased their pressure ulcer prevalence rate. This is a little bit of a complicated one, but it really plays to negative pressure therapy too. Because we have so much data, we not only collect every intervention that's done, we collect all of the products. So we collect every product that's put on the patient or the resident or the client, whatever, in this case, the resident. So what we can do is actually run a report on your residents to see what products work best with your population. So that's the other thing that data can do, right? So in this case, this was, we were actually looking at compression therapy, and what we were able to show with this compression therapy is that one type of compression therapy, and it was Coban, actually worked better in the first part of the healing cycle, but other compression therapies worked better in the next part. So data is so powerful because I want to go home and run the information on back therapy. Or not back, just negative pressure therapy because, God, we can actually look inside and say, okay, if people are using negative pressure therapy in long-term care, what are the outcomes? They leave it on for 2 weeks, so we can really track it down. So, and the other thing that we've done with our data is really look at statistical significance too. So it's not these numbers that we're throwing around. We have a statistician that works with us, and really we really try to make sure that the data is reliable and valid. But this is the problem. Are we using the right data to drive what we need to be driving here? So you guys use the IMDS, and certainly there is some difficulties with the way that data is collected around wound care, and probably yesterday people talked about that. But what I want to show you is a comparison. So Kai put out this white paper in 2013. And so what I did is I took just data from our long-term care. I looked at 16,000 patients. They looked at 138,000. But what they did is they looked at the compromised wound is what they were calling, and they have a definition for that within the paper. But one of the first things they did is combined arterial and venous. You can't do that. Two separate etiologies with venous leg ulcers can be healed in 4 weeks. Sometimes arterial ulcers can never be healed because it's a lack of circulation. So you can't do that. However, the percentage, if we look there, in long-term care is about 1.5% what they got, and our database was around that, but we could separate it out. This was scary. 6.7% of pressure ulcers in long-term care, our database says it can be high as 32%. That's worrisome. The other numbers, the same. Any chronic wound, they had at 7.9%. We say that's about 35%. Skin integrity problems, they have it as 0.9, and really it's about 14% in our database. I'm actually going to be working with Dr. Pamela Houghton out of the University of Western to get some of this information published. Because it's not a criticism of Kai. What it is, it's a different way of collecting data, right? They have administrative databases that they can pull a lot of information out. I guess what I'm saying, if you collect it at point of care with the same assessment tool that's more intimate, there's a different result in the data. The same thing. This was another. I looked at wounds in Kai. This is the Kai High. Just the prevalence of wounds were very low, 3%. Like in Ontario, 3.5%. And we did some comparisons, and it's astronomical the differences that we have right across the board in the volume of wounds. The other thing that we've started to do is we're building a predictive model with Tony that presented yesterday. So we're taking all of this data and we're now developing a predictive model for long-term care and home care and acute care. So you'll be able to put in what the factors that determine whether or not a wound will heal. So it's a mathematical model. So he's taking all of our data, developing a statistical model, and will actually be able to predict. So if you get a patient in one of your homes, by using this predictive model, you'll be able to determine the cost it will take and how long it will take to close. So we're really excited about that development, and that's really where we need to go with the data. So putting things into perspective. We have best practice. We don't use it consistently. We're measuring the problem with data that underestimates the prevalence and the cost. It's so risky. We do have the capability to measure it, and when we do, we get better outcomes. See why I put my head against the wall sometimes? And I found this online, and it was like, okay, that really sums it up. Every time I see a math word problem, it looks like this. I have 10 ice cubes and you have 11 apples, and how many pancakes will fit on the roof? And the answer is purple, because aliens don't wear hats. Like, that's the way I feel sometimes, that I'm speaking a different language. Because, and I don't need to repeat what I just said before. So, where do we go from here? What's this all about? And I was a little bit worried about using a hockey analogy after poor Mr. Trudeau, but it's not like that at all. I was looking for inspiration, because sometimes I sit home with all of this data and I think, how do we help people get better quicker? Like, how do we make a difference? And I thought about these guys. 3 minutes left, 2-0, they were down 2-0, and their perseverance was just unbelievable. And I think that's what we have to do. We have to have their mental strength, I think. We need to demand, and I mean demand, that policy changes are made with the right data. Like, we have to. We need to scream out for our residents. We have to do that. We have to track more relevant data, and I have to point finger at myself. We need to publish more, and that's one of our goals this year. The other thing is Paula. I don't think she's here, but oh my God, that woman. Bring accolades to Paula and her team for really bringing this real world data, the stuff yesterday and some today, to the policy table so we can make sure that your residents get the best care. The last one's a little bit risky too, but I'm really trying to think, because I was at a conference yesterday in St. John, and it was all around big data. And you do a lot of reflection when you have all of this data. We have to together persevere in trying to break the inertia in bureaucracy. We do. We have to. There's a resistance to change sometimes. There's a resistance to data, and I think we really just have to. We have to stand. We really have to stand firm on that. And that's my story.